I work at the epidemiology branch of the National Heart, Lung, and Blood Institute here at the NIH. And I am quite honored to have been invited for the second time to talk about health disparities research. I trust that we are going to explore and learn a lot during these next few minutes, and that you will take some messages home and be inspired and think about health disparities, how they can be approached, what are the needs, and how innovative we could be. I'm sorry, okay, here. So before I start, I need to acknowledge that most of the views, or all the views here, are mine and only mine, and do not represent the NIH. I will go over some definitions, over some factors or areas of study, and I'm going to also give you some examples from the literature. I would like to start with a real story that was on the news and also in research literature. Back in 1992, there was a report at the New York Times, which obviously is a newspaper from New York and is one of the main newspapers in the US, about an alarming rate of births in the Rio Grande Valley in Texas, births of babies with neural tube defects. And these babies were born to women of Mexican origin. In fact, nurses from the Rio Grande Valley had reported to the local authorities the births of 3 babies with neural tube defects within a 36-hour period, which is a lot in a very short period of time. After that first report came out, more babies were born with these defects, and not only in Brownsville, where the first report came out, but also in other towns and across counties in the Rio Grande Valley. By the way, Rio Grande is also called Rio Bravo. It's the river that divides Texas from Mexico. That outbreak or that incident had been preceded by an outbreak of equine leukoencephalomalacia that had affected or had been reported across the country, but it had affected Texas seriously in 1989. At that time, farmers thought that horses were getting this neurological problem from food, and they were removing food that contained corn, thinking that the corn had a toxin that was provoking this problem. So immediately there was an assessment or a conclusion that probably these birds, these babies that were born with these problems, maybe the corn had something to do with it. Nonetheless, the reports kept coming out, and 9 years later, it hits the Dallas Morning News that still this problem is happening in the Rio Grande Valley. And not only in 2002, it happened a few years later. So what did the local authorities do, or what researchers do? It is important to learn the context on when this was happening. 1992, just a few years before, there was a major US healthcare policy about fortifying cereal, breads, rice, food with folic acid, with the intention of preventing precisely neural tube defects, because a study in China and other studies had indicated that replacing or supplementing folic acid before pregnancy and during pregnancy seemed to reduce the births of babies with these defects. So that's when that policy came in, and women of childbearing age in the US were recommended to take folic acid supplementation. But in addition, like you may see when you buy cereal, you can see that it is fortified with folic acid. So it's quite contrasting that this policy had been implemented in the US, but this was happening in Rio Grande. So a group of investigators published a study that they did in 2006, precisely in the Texas-Mexico border, because they wanted to address whether corn or toxins in corn had anything to do with those births. So what they did, they recruited women who had had babies between 1995 and 2000, more or less, in that period of time, and they identified women who had babies with neural tube defects and women who had babies during the same period of time, but they were healthy. And they did blood tests, urine tests, and also interviews, nutritional interviews, specifically in terms of the consumption of tortillas, which are based mostly on corn, and other dietary intake. They found, and let me see if you can see this on the screen, that most women actually, the hypothesis was that women who made tortillas at home were probably at the higher risk of having babies with these problems. They thought the issue was the actual corn that they had at hand to make the tortillas. They found that most women purchased the tortillas rather than made them at home. They also found that there was an increased risk of having a baby with neural tube defects when they ate between 300 and 400 tortillas during the trimester. That meant about 3 to 4 tortillas per day, and which was in the middle. It was if they ate fewer or if they ate more, the risk was reduced. So it was something in the middle. But they also found that they measured the toxins related to the corn, and they found that there was a correlation between the levels of toxins and retrospectively having had a baby with a neural tube defect. What do you think about this whole story? And I have here, for those that are watching me on video, I have like 5 or 6 people in the room.
I guess it's targeting this Mexicans or Hispanics because of their diet, and it's probably losing a larger audience who could have been affected.
So that the study is targeting, or that is relevant to Hispanics and probably to a larger population? Because there are more Hispanics living in that area, in that whole area? Yes. Well, thank you for sharing your thoughts. This story illustrates the complexity of studying health disparities. It's not A and B, it's A, B, and C, and coming from different directions. It is studying all the factors that contribute to differences and how they can be remediated. But what does the term disparity mean, and why it is important to study them? And when we study health disparities, what factors we need to account besides the personal health factors, and what else we need to account? Very often, we see the term disparity used in the literature, and in reality, what the investigators mean is a difference. But there is a difference actually between disparity and difference. When we talk about disparities, we are talking about an element of injustice, of inequity, or a disadvantage. So if that's the premise, are all differences disparities? No. But we need to study them together. because they can accentuate, biological differences can accentuate disparities, and disparities can accentuate biological differences. So we need to account for all of them. Otherwise, we will have an incomplete view. Both are going to complement each other. Other terms that we usually see in the literature are equality and equity, but there is a difference. Equality is the standard, assumes that it's the same utilization of services for everyone, that everyone gets access to the same system, to the same services, to the same screenings, to the same treatments. So it assumes that everyone has the same need, the same preferences, and that at the end, the benefit will be the same for everyone. But does it assure access to necessary and high-quality care? Well, equality doesn't, but equity does. When we talk about equity, we think, and our goal is that the clinical need is the primary determinant for equal opportunities in utilization. So it is like the difference between giving shoes to everyone or giving shoes that fit. It is good that everyone has a pair of shoes, at least a pair, but do they really fit? So that's the difference between equality and equity. Also, we are talking about health disparities, but some think that actually the disparities are in healthcare. And the disparities in healthcare will result in disparities in health. It is very difficult to distinguish one versus the other. It's very difficult to separate them and only talk about healthcare disparities. It's not either or. I prefer to combine them because it's the whole. It's part of the system. We are multidimensional, and that's how diseases and health are going to manifest. So what is important to study health disparities is to ensure that we are reducing and eliminating health disparities wherever we find them, and implementing and delivering the best healthcare practices for our patients. That should be our goal. So let's talk about disparities in health or disparities in healthcare as research questions. This is an algorithm, a diagram that Dr. M.P.H published in 2009, in which he wanted to explain the different factors that contribute to the development of diseases in minority populations. And one of the key aspects of this algorithm or diagram is actually this, life course. This is extremely important. When we assess health disparities, when we study health disparities, it has become very common to measure factors one at a time or correlate factors one at a time. For example, correlate the prevalence of obesity with nutrition in one point in time. To correlate socioeconomic factors with diabetes control in a single period of time. But we also need to think and consider what has been the journey of that population, of that individual. Where was that person born? Was that person always healthy? Was that a premature baby? Did he or she have developmental problems, learning problems? Did he or she finish school? Was his or her family always in poverty or not? When they migrated from one country to another, did they remain in the same socioeconomic level? Did they go down? Did they go up? How has been their health over their lifetime? Instead of looking just cross-sectional, it is important to look throughout the life journey, because that is going to give us a very different but also very complementary aspect and assessment on how health is maintained or how disease is developed. So this is a different way of looking at factors, but definitely one worthwhile to pursue. So he addresses multiple dimensions, domains of what affect and ultimately result in a given health status: good, excellent, bad, poor. And it includes race and ethnicity, your identity, your genetic makeup, but also where you grew up, your socioeconomic history, your current one, of course, and then adversities, events that happened during childhood, your social network, how you relate to others, your family support, cognitive processing, of course, education, but also understanding beliefs, how disease manifests, how I can prevent, biological vulnerabilities, whether we have genetic disorders or whether I have family history of hypertension or hypercholesterolemia, or whether this is acquired, etc., etc. So the ultimate outcome is health. And it could be disease, it could be the maintenance of health. I believe that this diagram applies to every population, not only minority groups, the way they are called in the US. Everyone in the universe may fit in this diagram. This may explain a lot. The diagram is bidimensional. It's flat, it's on a piece of paper. However, these factors interconnect with each other like a sphere. So from now on, I'm going to try to show you how they correlate, but because we have a bidimensional way to show things, it's difficult to see it from different dimensions, but I want you to keep in mind that this is a multidimensional world. All right. I'm going to start with identity. And by identity, that includes your sex or gender, your race, ethnicity, your birthplace, migration history, your language. Along with your identity comes some psychosocial or sociocultural factors that are in your own culture. And language comes again. Then it comes with beliefs, practices, your social networks, and social support. And these are going to have an impact or an influence in your access to healthcare and how you utilize healthcare. And probably this has been the aspect that maybe initially was studied in health disparities research, and which has received a lot of attention. So I will go over some examples, but at the same time, I want to warn you that there is no single study that is purely A to B, B to C. There are multiple factors and multiple dimensions happening at the same time, or things that are lacking and that we need to pay attention to. So examples of relationships or associations between sex, gender, race, ethnicity to access to healthcare and utilization of healthcare services. This is an old publication that really caught the attention of the country. This was an analysis, a database analysis from Medicare patients. And those who are watching, some of you are from other countries. Medicare is a part of the health system in the US that is a health insurance for people 65 and older and people who have certain disabilities. One of them, chronic end-stage renal disease. When you work, you are contributing to Medicare during the time that you work. And then when you retire, that money that you contributed to, it's turned into a health insurance, which is Medicare. So this was a database of Medicare users, and the investigators wanted to specifically evaluate that group that had an acute myocardial infarction. So they found that over 200,000 Medicare patients had an acute myocardial infarction, and this was during a 3 or 4 year period. They found that according to the guidelines of that day, year 2000, 27,000 were eligible for reperfusion therapy. However, when they actually saw the claims database, who actually got the reperfusion therapy, they found that there were racial discrepancies. And what they found was that when they compared women to women, black versus white women, there was a difference based on race, but it became less. And between men and black men and white men, there was also a difference that was notorious. It was significant. However, when they compared men and women of the same race, the difference was not there. Okay. So once again, the difference was based on race, not based on gender among the two racial groups that they identified. So they observed that both men and women who were identified as black had received this reperfusion therapy less often and significantly so than white patients. And they were eligible. They met the criteria to have received this reperfusion therapy. That was the analysis. Can we say that there is a racial disparity, which is one of the health disparities that has been commonly studied? Is this a racial disparity? Yes? Why do you think there is a racial disparity? All of them have Medicare. So we assume that they have equal access to health care. They have full coverage, or the coverage at that time, it was for all of them. Same coverage, same health insurance. Yes.
Yeah, I was going to say, so far as we know, they're all eligible, so the entry criteria is the same. But we're still seeing a difference. It may not have to do with access per se, it could have something to do with personal bias or some other confounders that we don't know.
Okay, for those on the video, what is your name? Zion? Zion said that there could be some other confounders that we are not seeing there, and that's probably the answer. Just by looking at the claims-based database, we are only seeing who received the treatment, who didn't receive the treatment in a given period of time. We may see some personal identifiers, we may see some socioeconomic information, but there is information, like you have just said, decision-making. We don't know if the patients refused the treatment, if they were scared about the treatment. We don't know how the physicians communicated the need or the diagnosis. We don't know if other people made the decisions for the patients. So again, there are other factors that are hidden, but they are very relevant for the study of health disparities. So on the surface, it looks like there is a racial disparity. Are we absolutely certain? No. So it's a point where we can start then generating hypotheses and then try to come with surveys or more information from patients to determine what happened here. This is another study also talking about racial disparities in clinical presentation, and this is on breast cancer. And what the investigators found was, this is another example of a retrospective analysis from a database. They identified about 500,000 women with breast cancer. And they found that there was here that the therapy, mastectomy, was indicated in those women. But they found that African American women and Hispanic women had undergone a mastectomy with a fewer or a lower frequency than white women or even Asian women. American Indian women too, but their difference was not significant. So they find this difference in the actual provision or providing of the surgical treatment. And they wanted to also understand what happened after the mastectomy, if they also experienced the same rate of post-op complications or not. And they found that African American women experienced 34% greater likelihood of complications than women from the other races or ethnicities. They also found that in-hospital mortality was super higher among African American women. Now, we are talking about much fewer, lower number of events, and the significance was not there. Nonetheless, they are reporting differences in outcomes. A difference first in receiving a treatment that is indicated, and then differences in outcomes. And African American women are at the highest risk here. Do we know for sure that these are racial disparities? We don't have sufficient evidence to support that. It could be not. It could be that the way they presented with more advanced disease. It could be that they had other coexisting medical conditions that could explain this higher rate of complications. In terms of the mastectomy, we don't know if they refused it. We don't know how long between the diagnosis and the surgery, the time lapse between the diagnosis and the surgery. We don't know how was that interaction between the health provider, the physician, the surgeon with the patient. All of that affects, is confounding these results, but we don't have that information. So we are talking about identity, and the immediate indicator of identity, sex, race, birthplace, migration, how that also come with biological factors. I am not saying that we are from different races, and we know that the term race is a social construct, and it is used and interpreted in the US and in different countries in a different way. What I'm referring to is what comes with our heritage, with our ancestry, regardless of the race, regardless of how we look, what we bring with us, and what is in our fetal development, in our early development, that translates into health or disease later in life. So along with our identity, we also come with our biology. And of course, all of them are interacting and will result in some health outcome. Talking about race, ethnicity, ancestry, origins, this is a graph showing, this is a report from 2012 showing the longevity or mortality among the three largest race ethnic groups in the US: Hispanics, African Americans, and non-Hispanic whites. And what the report stated is that Hispanics as a group live 2 years longer than non-Hispanic whites and 7 years longer than African Americans. And among Hispanics and among everyone, Hispanic women live the longest. Does that mean that non-Hispanic whites and African Americans are at a disadvantage compared to Hispanics? No? Yes? No? If Hispanics in general, because Hispanics are a hugely diverse group, but if Hispanics do suffer adversity, and there are many groups, like the one I presented at the beginning, who live in very poor areas, isolated areas of the country. If that happens in major areas in the country and in major Hispanic groups, similar to many groups of African Americans throughout the country, if they are suffering or if they are experiencing similar adverse factors, socioeconomic factors, but they are living longer, again, is that an advantage, disadvantage? Who is in the advantageous position, or who is in disadvantage? Or is that the correct way to see it? We don't have enough information. We are looking at one outcome, longevity or mortality, depending on how you want to look at it. But what is happening in between birth and death, we need to study that. We need to understand how the health of those individuals has been. We need to understand, besides the health, the biology, social factors, cultural factors, other factors that are influencing that longevity. Does that mean that Hispanic women live longer and healthy? We don't know. Does that mean that they live longer and with disability? We don't know. It's just a description. Now, using breast cancer as an example, breast cancer again. This article was published last year at JAMA. And it really presented very dramatic findings among different race and ethnic groups in the US. And one of the main findings was this was, again, a huge database of 500,000 women with infiltrative, breast cancer. And in this particular table, we are seeing those which stage 4, which is the more advanced stage. Before we get to this one, they found that African American women and Hispanic women had the lowest rate of lower stage. In other words, that at diagnosis, they had already an advanced stage compared to the other groups. Now, in this one, which is the most advanced, they found the following. They found that Black women had about half a higher probability of an advanced stage at diagnosis, and this is in tumors that are small. This is not in large tumors. Hispanic had 1.2, which was a little lower, but compared to non-Hispanic white women, still higher. South Asian women also had a similar risk than Hispanic women. Black women had the highest risk or prevalence of positive nodes. That means that the tumor had, although the tumor was small, had already expanded beyond its borders. Hispanic women were following them, as well as South Asian women. Now, in terms of the characteristics of the tumor, Black women had the lowest prevalence of tumors that were estrogen receptor positive. And that's an indicator of probably lower sensitivity to hormonal therapy or chemotherapy or the therapy for breast cancer. The rest of the women had a similar prevalence of ER-positive tumors. And triple negative tumor means it's a tumor that is really not sensitive. In terms of the characteristics, it's going to be a hard tumor to treat. And black women had the higher prevalence of this type of tumor. So what does this mean? Is this a racial disparity? Is this a biological difference? A biological difference. Most likely. Now, the authors also bring up, they evaluated survival. And they observed that South Asian women also had a relatively high advanced presentation. They also had positive nodes. However, their longevity was longer than Black women's. So they clearly demonstrated a biological difference, but they thought that the biology did not explain completely the difference in mortality. And again, there are factors that really cannot be measured in this analysis because either they were not collected, assessed, or they need actually to be assessed. I'm sorry, okay. The same disease, breast cancer. I showed to you this big study with women from different racial ethnic groups. Now, a question about Hispanic women has been, well, they present with more advanced disease because they have less access to medical care, which is a problem in the Hispanic population in the US. For decades, they have had the lowest prevalence of insured people ever compared to any other group. So in this study, the investigators wanted to investigate whether having health insurance or not had an impact in the stage of diagnosis at presentation. So this analysis was done from a major health system in the US. That means that all the women in this analysis had health insurance. They had the same screening. They had access to the same doctors. In theory, they had access, period. And what they found is that despite a similar access to the rest of the population in that particular health system, at presentation, Hispanic women presented with stage 3 or 4. Their tumors were poorly differentiated or undifferentiated. They had large tumors, and they were not ER positive, or they had tumors that were larger, that were undifferentiated, and probably not sensitive to treatment. So again, is this a disparity based on access to health care? Is this a biological difference? This is an example of something that points towards a biological difference, but we cannot rule out other confounders that could be present. Another study showing the heterogeneity of breast cancer types among Hispanic women in California. And what investigators found in this particular report is that Hispanic women in this particular analysis tended to have the most aggressive or less sensitive types of tumor, and also experienced a lower longevity that was very correlated with low socioeconomic level. This study took the analysis a little further and introduced another factor, socioeconomic level. Why socioeconomic level would influence or would have a relationship with biology, we don't know. But it was a consistent finding that women of lower socioeconomic status had very aggressive tumors or more aggressive tumors than those who came from higher SES. This is not about a disease. This is a treatment for a disease. This analysis is about Medicare beneficiaries who have heart failure. And investigators wanted to understand the interaction or relationship between race, ethnicity, disability, and adherence to medications in this group. So what they found is that they found a difference between adherence, among 5 groups, racial ethnic groups, that those patients who were white had the higher adherence, whether they were older or whether they had a disability, compared to the other racial ethnic groups. And they wanted to understand this further. And they went ahead and they wanted to evaluate whether having double insurance, in this case, there are another insurance called Medicaid, which is an insurance for people who are medical indigent, people with low income. And in some states, elderly or patients who are under Medicare are also eligible for Medicaid. So they wanted to know if having double insurance or dual eligible, whether the economic scale according to the federal poverty level, which is a cut point in the federal government to determine poverty, whether that has an influence in medical adherence or not. And what they found is that even by trying to adjust or correlate with these 3 items or factors, the differences among the races and ethnicities persisted. So is this purely race, that my race determines how adherent I'm going to be to medications for heart failure? No. What is it? Is it that I understood the instructions? Is it that I understand what it means to have a chronic disease? Did I understand that I need to take this medication not just for 30 days, that I need to go back to the pharmacy and pick up the medication, or that I need to be reevaluated? And again, religious beliefs, cultural beliefs about chronic diseases. What is it that is causing this difference? We don't know based on this analysis. So we talked about identity, about biological factors, and health status or health outcomes. Well, we also have stress and stressors that influence health outcomes and at the same time influence biological factors, which in turn influence health outcomes. And by stressors, we often think about acute stress, an acute period of stress, an acute event, a death, an accident, I lost my job, I lost money, I underwent some kind of stressful situation at work, my neighborhood. But there are longer-term stresses that start during pregnancy, before birth, stresses that go throughout life, major events in our lives, going through war, going through discrimination, going through migrating because I need to leave a very dangerous situation, stresses that are continuous and are there and are affecting our biology, and how where they come from the outside, factors that we cannot change, politics, in country relationships, are they coming from within our family? Are they coming from our neighborhood? Are they coming from our local government? So there's a variety of stress and stressors and how they impact health. There are many examples. I picked these 4 that I am not going to elaborate that much, but the first 3 about perinatal health and about how the woman's health during pregnancy affects the child has become quite a topic of high interest, and fetal programming or pre-programming. How we have studied adults and studied, for example, the onset of chronic diseases in the adults. But now we are discovering more and more evidence that we need to look back in time, look at childhood, look at the development, but even look at the fetal development, how the health of the mother, how that mother behaved, the nutrition, and the circumstances when this baby was being formed, and how adverse events to the mother affect the baby and leave long-term sequelae in that manifest sometimes during childhood or later in life. But this chronic stress also happens in adults and affects the health of adults. It doesn't have to start in childhood. An example is, in this case, is survivals from the Jewish Holocaust. But there are other studies that show similar or circumstances that are of intense chronic stress that mark a life forever. And they definitely will have an impact, not only psychologically, but also biologically, and these have to be accounted. So besides stress and stressors, then we have psychosocial, sociocultural factors that actually counteract or serve as the resilient factors against the stress, and that also have a direct effect on either the stressors or on the biological factors. And in addition, the cognitive processing, not just memory or how we speak or if we do math or not, is how we learn to understand the world, how we interpret the world, how we acquired that vision of the world about health, about us, about others, that we learn that from our culture, from our family, from the people who surround us, how we form those norms, that those also affect our health because those are going to influence on our decision-making about our treatment, our medications, prevention, and even education. So let's move into some examples. The first study is about an analysis or an evaluation of immigrants, adolescent immigrants in Spain. The investigators wanted to understand, first of all, whether adolescents in Spain, whether they were born in the country or they were immigrants, if they experienced the same prevalence of substance abuse, which is a problem in Spain, and it's a problem in many countries around the world. What they found is that adolescents who were immigrants actually experienced lower prevalence of substance abuse, but that was more pronounced among those of Muslim either upbringing or in which in the household they were practicing Islam. This is not a particular prescription for a religion. What they meant and what they discovered, it was not only the influence of the religion, but also the influence of the parents. Is how that feedback, how that network, how that support, and how your parents instruct you and educate you has a lot to do on how you are going to make decisions later. Another group of investigators also in Spain wanted to evaluate the epidemiology of psychiatric morbidity among migrants. And they found that actually in general, when they talk about migrants, they talk about migrants from different parts of the world, from Latin America, Sub-Saharan, Central Europe, etc. What they found is that when you put all the migrants in one group, the prevalence of psychiatric illness is very similar to people born in Spain. But when they then looked at different subgroups according to geography, where they came from, they observed that immigrants from Latin America had a higher burden of psychiatric illness. This was a surprise to them because they thought that what Latin American immigrants may experience coming to the US, one of the issues is language barriers or the acculturation or not understanding this culture because this culture is different, or how do I fit in, how do I navigate the culture. They thought, well, one of the hypotheses is that Spain and Latin America, they share some cultural aspects, they share the language, that the interaction would have been easier, or that transition from their country of origin to Spain would have been easier. But they didn't find that to be true, or at least from the findings, they didn't think that was what happened. And it deserves a more exploration and study. So these are two examples on health behaviors, on beliefs that we acquire and how they interact with our health, and they manifest in health or disease. Now, another aspect of health disparities that we need to account on is access to healthcare and utilization. It's a cycle or a circle. I may go to the doctor because I feel bad, or I may go to the doctor because I want to prevent a disease, or what is the reason I go to the doctor? Why is the reason I seek health care and where I go for that health care? And what happens next? Is access to health care the answer to everything? We know that giving access is opening the door, is bringing the patient to the door. But what happens in that interaction between the patient and the healthcare provider, that the patient makes a decision, or the health provider makes a decision, makes a diagnosis, what happens then in that journey to either prescribe a treatment or a preventive strategy or screening test, or to do it or not to do it? So there are three examples here of countries with well-established and well-known health systems, and actually very organized societies in Scandinavia. And despite having clinics with low cost or no cost counseling to prevent pregnancy, and even a reimbursement for oral contraceptives, even when that's available to all women, they have found that there is a great number of young women, younger than 25, who undergo abortions. And obviously, one of the main reasons for having an abortion is because the baby was not expected or intended. So if there is the availability of a service to prevent precisely those circumstances, why is it happening at such high rates? So this is an example that the system is not the response or the answer, to everything, that there may be some personal factors that we need to understand. Why is this woman making this decision versus preventing the pregnancy? And again, it's a fertile area for research. This, on the other hand, is a study done here in the US, and it was about medication adherence in the Latino population. And the investigators found that actually most of the responders to this survey did not have any specific reason for not picking up medications in the local pharmacy. We often think that patients have certain barriers or experience certain barriers, but sometimes they do not. However, let's look at this table carefully, because the majority said that they have no specific reason. But when we add up these three, communication issues, logistics, and limited pharmacy hours, then this number is much higher than none. So the medication adherence here doesn't seem to be related, at least from this survey, to the patient not understanding the health or disease or risk factor, or the physician not explaining it. And in fact, there are other tables in that particular article that show that patients felt very comfortable with American pharmacies, that they had no issues in communications. There are other factors like transportation, like distance to the clinic, that are mediating these differences. But we often don't ask these questions, and we assume the patient comes to this clinic and the patient receives the prescription, will pick up the medication, but we don't know what happens in between. So again, these are factors that we don't measure often, but are interfering with the treatment of this patient and actually accentuating disparities or creating them. And the example that we saw before, not related to the access to health care, these women had access to health care, these women had access to screening, a mammogram, but they presented with more advanced disease. So again, it's not all about the access. Access is important, but it's not the answer to everything. Biological, cultural, sociological, transportation, geography, all those factors affect outcomes. We also need to look at factors in the system that may be creating, perpetuating, or enhancing in a negative way disparities. And I'm going to present you several examples. This is actually it's kind of an opinion review from a hospital in Chicago. And they bring up a very important topic. There are certain hospitals, certain areas in the country that serve the underserved. Therefore, they are going to have a particular population with socioeconomic characteristics and burden of disease that are going to be quite different from other areas in the country or in the same county that serve individuals or populations with higher SES. Their concern in this particular paper is that with the implementation of the Affordable Care Act, which is the healthcare reform in the US, institutions like this one who serve the underserved and have a high burden of patients who are very sick, they need to meet and to set the standard of quality of care and be on top of providing care to these patients. And there are some metrics under the Affordable Care Act. They are afraid or concerned that because the volume of patients is going to increase, that they would not be able to provide the services that they need to provide, and therefore they are going to look bad, when in reality they are doing the best they can. So they want to come up with creative approaches in order to extend the care and prevent readmissions, prevent hospital problems with these patients. And they talk about even, the use of community health workers, navigators, people who are connected with the families, and that patients can manage their disease better at home rather than coming to the hospital to manage the disease, health informatics, etc. Even creating a peer groups, peer coaching, and that means patients who have the disease, who have understood and managed the disease well, they can teach others how to do it. Again, these problems in the system that could accentuate disparities, but how they can also be solved. In the world, and I mean the whole world, there is, if there are health disparities, one group that is really underserved is the group of patients with mental illness. And I am not a psychiatrist, I am an endocrinologist, but in real life, you see it every day. And in this particular paper, which is another position paper, is bringing up the awareness of this issue. And what caught my attention, all the points that they bring about recommendations to clinicians, do not forget the people with mental illness, that they get other diseases too, is precisely the one I marked with the oval here. That patients with mental illness, in the picture of the mental illness, they come with symptoms, somatic symptoms, and if we are not careful, we may think this is part of the psychiatric illness and not actually a separate illness happening. And we may be omitting or postponing the diagnosis of something serious. So inadvertently, we as providers could be creating a disparity if we are not paying attention. A similar situation with autism. This is another commentary. And this is to raise awareness again about the diagnosis of autism and the access to these screening and treatment services. One of the issues that are highlighted in this particular paper is the scales or the diagnostic tools that are used to assess or diagnose autism. The authors claim that these tools have been measured and validated in non-Hispanic white populations and have not been tailored to different cultures. And that may be a problem because the scale, then the responses to the scale or the tools may not be reflecting the actual pathology in children from other cultures. So that's also important to bring up because this is a diagnostic tool they are talking about, but also in research, in epidemiological surveys, even in clinical surveys, there are standard questionnaires for a variety of illnesses. Some that were they were drafted long time ago and they were validated, but some of them may need an update because they were validated in a specific period of time with a specific population, and the population has changed tremendously in 30 and 40 years. So that may also need a revisit. Another example of something that we could be doing inadvertently. In this particular survey about colorectal cancer screening, health providers were interviewed. And the bottom line of this paper is that for a long time, the screening test for colorectal cancer was a sigmoidoscopy or a colonoscopy, depending on the patient, which is a visual and direct way to see the colon, of course, and if necessary to take biopsies. But other ways to do it, like a cold blood or even DNA in fecal matter, have become more available, are easier to do, less expensive, and you could do it in a very large number of people within a given period of time. For a colonoscopy or a sigmoidoscopy, you cannot do 200 in a day, for example. So, and the certainty of the test in diagnosing colon cancer is quite close. So the investigators wanted to know the attitudes of the physicians. And despite what we know about diagnosing or the screening test for colon cancer, physicians still prefer to refer patients to a colonoscopy or sigmoidoscopy. And in many cases, some patients cannot afford it. It may not be covered or covered by a medical insurance or partially covered. It takes time. There is a preparation involved. And it's contrasting something available that is simpler, that yields a very similar result with something more complicated, and how we could probably change on how we think and assess or diagnose more people earlier and treat them earlier if necessary. Other examples, when we have people from other parts of the country living of the world living in our country, and we recommend treatments or screening tests based on what happens in this country. But very, 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 very seldom we think where this patient is coming from and what are the diseases that are prevalent in the country of origin that I should be paying attention to. And these are 3 examples. A Chagas disease, which is highly prevalent in Central and South America, is something that physicians are used to and they screen for, and they know the prevalence in different countries. But we seldom think about Chagas in the immigrant Latino population in the US. A disease that actually causes fulminant heart disease is the end result, heart failure is the end result of the infection. But we don't think about an infection causing heart failure. We think about hypertension, we think about diabetes, we think about structural abnormalities of the heart, but thyroid disease, but not very often about an infection. And then we are missing those patients by not knowing that we are not providing the care that they need or the screening that they need. Similar examples are gastric cancer in Central America or even South America. Here in the US, we screen for colon cancer, but in Central South America, they also screen for stomach cancer, something that is not done here. So we also need to think where the patient is coming from. And another example is diabetes, how it manifests in different populations, and how we may miss the diagnosis and the prevention or even the treatment, not providing the right treatment for the patient. If I believe this is a final example, another way in which in the system we could create certain disparities is communication. And this is a topic that also has been brought up in other forums, is the interpreters. We are in need of interpreters of many languages in our country and in different countries in the world. This is not just in the US. It is very often thought, okay, interpreter is one who can speak the language. Well, that may be part of it, but the interpreter, it has been shown that if they know about medical terminology, if they know about the disease, but also if they know the culture and how things are said in a different language, that will certainly help better the communication between the provider and the patient. And in these 2 studies, they found discrepancies between what the interpreter said and what the doctor actually asked. And this doesn't happen in one language, this may happen in other languages. So educating our own interpreters with more health literacy or even medical terminology inviting them to be part of procedures and the whole interview and assessment will be very helpful. These examples are not health policy or health related directly, but impact health. Examples of public policy, of other policies or other factors that are going to influence the health of a population or an individual. Racism, it exists everywhere, with a different name, with a different color, with a different accent, with a different vocabulary, but it exists. And like it or not, it influences how we see the world, how we see others, and how we react to others. And when that interferes with justice or with appropriate care or treating people with the respect that they need, then we are in trouble. And of course, how policies take a long time to change, or the effect of a policy once it has been changed and implemented, it takes sometimes decades to really see a difference, a palpable or tangible difference in the population. Some have asked about cancer and genomics and health disparities. And I do believe that genetics offer a great value and is another dimension of understanding diseases. But it's not the whole answer, of course. Now, in order to understand how genetics really define or how we are going to make decisions about genetics, we really to measure the variation across the population. I think that we are advancing, we are not there yet. And that's in terms of the use of genetics and in terms of the value, which is growing. And we keep doing it, and we are going to learn more, but we're still learning. The concern of some is access to these tests eventually, whether everyone will have access to them, how they are going to be interpreted, and after the interpretation, what to do. What is this going to mean for our health or for our treatment or to prevent something in our family? So these are debates and issues that's still going on that are necessary in order to build very good structures that offer access and health care and assessments to everyone. Last year, I had a picture of a jigsaw puzzle or some figurines holding different pieces of the puzzle. However, understanding health disparities and doing health disparities research is more than a puzzle and bidimensional. It's actually more like a Rubik's Cube, that you attempt to do one side, and then you realize that the other is incomplete, and you have to redo it again until you get two sides well, and then you have to do the third side, and you have to redo it all over again until you get the whole cube done. That's how I see health disparities. It's just an interaction among the different factors. You don't get a straight answer with just one factor or just one side. You need to account for the others to have the whole picture. Why is it important to continue doing research in health disparities? I mentioned this at the beginning, and I would like to repeat it. It's to ensure that we reduce and eliminate health disparities wherever we find them, and implement and deliver the best health care to our patients. When we propose to do research in health disparities, what do we want to do? Or why are we doing it? To document, to explain, or to strategize? If we want to document a disparity, why are we doing it? Do we want to write about an already recognized factor, or do we want to explore a new factor? Do we want to revisit a covariate and understand how it is its role in the development of disease or not? Or do we want to study a new population? Or do we want to study the same populations? Do we want to document what has already been documented? Or do we want to document something new? And once it is documented, are we looking for an explanation? What would be the next step? Are we looking for mechanisms of disease? Are we looking to understand health outcomes, clinical outcomes? And if so, if we understand or explain clinical outcomes, what are we going to do with that explanation or with that knowledge? Are we going to then formulate new hypotheses or policy? What are we going to do with that information? If we are going to study health disparities because we want to strategize on reduction or elimination of these disparities, do we design interventions? Do we reframe or evaluate what we already know? Biological factors, clinical outcomes, utilization of health services, policy, socioeconomic factors, environmental factors. Are we looking at all these factors, or are we just looking at one? Is it possible to look at all the factors in one particular research study? It's very, very hard to do that. Either you select a very specific population and you study all those factors, or you assess more people and fewer factors. But the important thing is that when you are analyzing your data and formulating conclusions, that you understand what your strengths in the analysis are and what their limitations are, and use the limitations as new hypotheses for more research. But don't conclude anything as black and white. This is the end, period. Continue understanding what is happening. I see the research on health disparities as an opportunity to thinking out of the box, to break with the norm, to break with the paradigm. And a lot has been published. Maybe it's time to review what has been published and formulate solutions. And maybe solutions that we haven't even thought about. Maybe our patients can help us generate solutions. Maybe outside of the scientific community, we can find solutions. We can build multidisciplinary teams to build solutions, to create solutions. Sometimes we study health disparities from the standpoint of a database. But sometimes we need to study health disparities directly with the population and to get that information to really understand what's happening. And sometimes that population is very hard to reach, and they will not come to a traditional clinical setting. So what do? You may either not do anything or create the opportunity for them to come to you and understand them. These are examples of an initiative in Puerto Rico, and the doctor there is Dr. Vargas Vidot. He had a special calling to serve the underserved, but specifically people with addiction, sex workers, people who have very, very intense and extreme life circumstances. And he understood that even if they wanted, they wouldn't come to their normal clinic for health care. So he created the clinic for them, and he went to them. And in the illustration on the top, it says, ¿Por dónde empezar? Where to start? Where do we start? So that's how he started, by going to them, but by understanding them, by going to their level and understanding their circumstances and not judging them. So I hope that I have brought something new to think about in the health disparities research area. That health disparities exist, they come in different tones and voices and aspects of life. They come along with biology, they come along with religious, traditional beliefs, they come along with language, they come along with the skin tone, they come along with age and gender and sex. But we have an opportunity and we have also a responsibility. And I hope that either you who are watching or those in the room, that if you are pursuing this field, to think about the great contribution that you are going to make. I am quite honored to have been here talking about health disparities, and if you have any questions, please. I think we have 10 more minutes, or even more. They told me that it's unlimited, so thank you for being here today. Thank you very much.